Darin Hovis here at Par 4 Fitness. I'm joined again by Ailsa Clark. We're going to be talking about some of the principles of rehabilitation and reconditioning. So Ailsa is going through her CSCS. She's got her exam coming up, and she's also graduating this weekend. So hopefully some things that you can apply as foundations of rehab and getting back to returning to golf or whichever sport you enjoy. So some of the things that we're going to be talking about are who's involved. Studies show that over 80% of golfers are going to experience some type of injury over the course of their career. Some of the principles behind rehab and reconditioning, the types of injuries that will get exposed to, soft tissue, bony tissue, etc. The process that the body goes through in healing, some of the goals of rehab and our process of reconditioning you. Sadly, one of the biggest precursors for re-injury is past injury. So for us, that's on us to do a better job of getting players back to course when they are ready, and not rushing them back to play. Some of the program design that we'll use for rehab and reconditioning, and then rounding it off with how do we reduce the risk of injury and re-injury, which I touched on briefly. So I'm going to turn this over to Ailsa, and she's going to walk us through our first slide.
So who's involved? So as a student athlete at FGCU, we have a lot of people involved in taking care of us, making sure that we are fueling our body physically and mentally. And so these are just some of the people that are involved. So in any sports medicine team, if you go to the NHL, if you go to the NFL, even in college, there's always a team physician. So there's a medical doctor who is primarily used by the university. So every fall, my teammates and I, we have to go in, we have to get a pre-participation exam. So we have to make sure that there's nothing going wrong internally, nothing going wrong externally. They put us on an EKG, check our brain waves, make sure that everything is going on there. There's also a certified athletic trainer. So in my program specifically, I was in the exercise science program, and the exercise science program and athletic training program work together. We both took a lot of the same courses. However, theirs is more geared towards athlete rehabilitation, whereas ours is more toward exercise selection and designing exercise programs. So in our athletic training facility, there were 2 certified athletic trainers, and then the interns who came in, so such as I'm interning for Darin, there were also athletic training interns who participated in this site, and they were really focused on managing and rehabilitating injuries. So athletes would come in, check to see how they were doing, and it was this person's job to determine whether or not the athlete was ready to return back to exercise, back to working out with the team. So a lot of people think that it's the strength and conditioning coach, but it's actually not. The strength and conditioning coach is not certified to do that. I'll talk a little bit more about their role in the next slide. There's also a physical therapist who is certified through the American Board of Physical Therapy. And they are used to develop specific treatment strategies. They're kind of like the team physician as well. They usually come in at the beginning of the year, or they come in when they're needed. They're not necessarily constantly within that facility.
Right. Yeah, in my experience, at least in the NHL arena, working with the Everblades as their minor league affiliate, the athletic trainer was really the only one on staff for the strength and conditioning, as well as getting back to the ice. So sometimes you're under the watchful eye of the team physicians, which aren't there day to day. They'll come in if there is an injury, evaluate maybe even in their clinics, and then they're getting the athlete cleared. And then the athletic trainer and the strength and conditioning specialists, it's their jobs to get them back to a state where they can compete at the top level.
So then there's also a strength and conditioning professional who is certified by the National Strength and Conditioning Association. That's what I'm sitting for, the CSCS. This person focuses on building strength, power, and performance of the athlete. So whenever I go in the mornings for my weekly workouts, This individual is in charge of spotting us, making sure that we're handling equipment safely, and making sure that we're using proper technique to avoid injury. There's usually an exercise physiologist who, in the event that the athlete is rehabilitating, is working through the healing process. This person works with the strength and conditioning professional, works with the athletic trainer to design a specific program that will benefit the athlete. There's also a registered dietitian or nutritionist who is available to assist in food choices for the athletes. And the most important person I consider is the counselor, psychologist, psychiatrist. You can take care of yourself as physically as you want, but ultimately, in order to be successful in your sport, you have to be mentally there. You have to be mentally available, mentally focused in on what you're trying to do and what the team's goal is. So there's this licensed member who assists in the mental stress that can accompany an injury, that can accompany traveling, focused on schoolwork, how to balance everything. So I think that person is quite important to this sports medicine team.
Yes, and I think organizations are doing a better job at including that healthcare professional into the team, where they might not be a paid member of an organization, but they do have the resources to access the players, and vice versa, the players, if they do need that type of help, then they are readily available whenever they are needed.
So there are 5 significant principles of rehabilitation and reconditioning that are listed. A couple of them I'll go into a little bit later. The first one, healing tissues must not be overstressed. So whenever an athlete is working through an injury, there's only so much that area can take. So during this time, the athlete really needs to be aware of the difference between loading. So if you took a basketball player and you took a cross-country runner, the basketball player is probably going to be able to take a greater amount of load due to their size difference, due to their level of strength difference. So if they both had ankle injuries, the basketball player is probably going to be able to lift more as the healing process continues compared to a cross-country runner. One is more power-based, one is more endurance-based sport. So you see that difference there. Athletes must meet certain criteria to advance from one phase to the next. So in order to advance from phase 1 of rehabilitation to phase 2, maybe the athlete needs to be able to stand on one leg without any support. Or maybe he needs to advance from that to a calf raise, or advance from a calf raise to skippers, or advance from skippers to sprinting. So there's so many different phases that the athlete has to meet in order to advance to the next phase. Otherwise, we're just going to re-injure and have to go through the whole process again. The third point, rehabilitation must be based on current research. That's why it's so important that the athletic trainers are working to continue to see what new information is being produced. The book that I'm working through right now was written in, I think, 2016. So that's 4 years ago. We've got constant new information, new research being done, so it has to be updated. The fourth point, rehabilitation programs must be adaptable to each athlete. Every athlete's different. A basketball player is going to be different from a golfer, is going to be different from a soccer player, is going to be different from a gymnast. We all have different injuries. We might all have the same body parts, but we're all using our bodies in different ways, different directions, different planes of motion. So it's really important to be able to adapt from this sport to that sport to the next. And then rehabilitation is team-oriented and requires all members of the sports medicine team. So the sports medicine team are the people that were listed on the last 2 slides. Like I said, the athletic trainer and the exercise physiologist and the strength and conditioning coach, they need to be able to communicate with each other to understand, okay, this is the exercise regimen that we're going to have this athlete go through, and these are the exercises they can do. This is the max number of reps they can do in order to prevent re-injury.
Right, and going back to the current research, this is why I always kind of advocate going through journals, staying up to date on certifications and things like that, because that's where the new research lies, and they'll give you insight into what they are currently researching, what they've tried that's worked, that's maybe better than the current research that's out there, because the books and even the journals are a year or more behind, right? So things vastly change in that period of time, especially in the sports medicine world. So it's important for you, if you're watching this as a healthcare professional, to look for those other outlets for research. Over some of the types of injuries that we could see.
So the two most significant ones are macro trauma and micro trauma. So a macro trauma is going to be very sudden. It doesn't happen over time. Micro trauma is more overuse. So over time, if the athlete continually uses that muscle or strains that muscle, that's where, or it could even be a joint, a ligament, whatever it is. It's going to be more over a period of time, whereas macro trauma is going to be very sudden. If it's a bone trauma, it could be a contusion or a fracture. So the difference between those is just whether or not it's going to be a full or not, or partial tear. And then if it's at the joint, then dislocation is going to be, once again, complete displacement, whereas subluxation would be a partial displacement. And subluxation is going to be a more instability based. So the athlete might be able, you see basketball players get up off the floor and they're like, oh, I'm fine, but they're really unstable in that area, in that joint, especially if it's, an ankle or knee specific ones that we need. And then a ligament trauma is actually a sprain. There are 3 different degrees. If you want to search into that, you can, but it's basically just the difference between partial and complete tears and whether or not the athlete has full or partial instability. And then going into muscle trauma, you can have a contusion or a strain. A contusion is going to be direct trauma and a strain is going to be indirect trauma. So if it directly hits the bone, directly hits the muscle, or if it tears the muscle fibers, that's how you can determine whether or not it's going to be a contusion or strain. Within microtrauma, the most common is a stress fracture, and that once again is just overuse. I think the most highly anticipated microtrauma that we see is within the knee and the ankle, especially within soccer players, just constantly running, having to turn as fast as they do. Then that is one of the most significant areas there. And then tendonitis is inflammation of a tendon.
And a lot of golfers will experience micro traumas as well, especially touring professionals and players that are playing a lot, is because they're putting these unique loads on the body over and over again. And so it's one-sided, right? So we have a higher prevalence of osteoarthritis and musculotendinous issues as well, even like nerve type issues.
Right.
That's also something that you could even classify as a micro trauma for golfers. And then a tendinosis would be more like a long-term inflammatory phase of an injury, specifically of a tendon.
So in the process of tissue healing, there are 3 different phases. We have the inflammatory phase, fibroblastic, and maturation remodeling. So in the inflammatory phase, it's usually 2 to 3 days following the injury. If we have this issue, then the area is going to become red, swollen, and painful. We're going to have an increased number of inflammatory cells. So all of the cells are, you can think of it as flocking to the site, and that's where we're growing with the inflammatory cells, and that's what creates a lot of the pain for the athlete. And then leading into fibroblastic repair, that's going to be a couple days after this inflammatory response, and it can extend all the way out to 2 months. So the tissue that has been affected is going to break down, and it's eventually going to die. And then as new tissues are placed in, then this area is going to be very weak because we're building this tissue back up, if you will. It's the one that was strong broke, and so now we have to add back in. And collagen fiber production begins here. It's actually type 3 collagen fiber production. And then when we advance to maturation remodeling phase, this is months to years following the injury. The collagen fibers begin to hypertrophy and align properly. We advance from type 3 to type 1 collagen fibers. And during this phase is when we can really start to rebuild that level of strength that the athlete held prior to injury.
Excellent. I think one of the biggest mistakes that people make with with injuries in general is just throwing ice on them, especially like past that 2 to 3 days in duration for that inflammatory phase. So what that'll actually do is kind of prolong the inflammatory response, which, as we see here, is step one to healing. So we actually want that inflammation to occur. Now, in the case of somebody hits in the face with a puck, that would be something that you would want to put ice on to try to diminish the inflammatory response there. But in general, ice is usually kind of counterproductive for tissue healing. What are the goals here, Ailsa?
So, excuse me, each individual athlete is different. Like I said before, each one is going to respond differently depending upon what area is affected. And the two primary points that the book highlighted was the number one point: healing tissue must not be overstressed, going back to the importance of choosing the load, how it's going to be different from sport to sport, and how some sports might be able to carry more load compared to others, and then meeting the specific objectives before advancing from phase to phase. This is, once again, the responsibility of the sports medicine team, really the athletic trainer saying, okay, this individual has, gone through this part of the rehab process. It's okay to begin exercises again.
Right. So it's important that you're with a professional that is going through a bit of trial and error. I say that lightly because you don't want error in that system, but we do need to have stress. So we're kind of towing that gray area. Being too conservative is going to prolong the time to healing, and as being too aggressive is going to prolong that time to healing. So we have to find that delicate balance of, okay, how much load on the tissue is good, and what's going to kind of set us back. So some days we might feel great, where others we might feel like this is starting to kind of taper back a little bit. So, okay, we have to look at the program, identify, okay, maybe this is where we need to take a step back in this area, and then we can move forward after that. So just trying to find that delicate balance, and that's especially different from player to player too. You look at like Adrian Peterson, who had an ACL tear and made it back in record time, kind of blew out all of the protocols, and made a lot of people look at, okay, how are we analyzing players? Are we just going through the 6-month system that's been the same for everyone? Whereas this guy's totally different. He's coming off of an injury where he was healthy, had a very successful surgery, and he may be able to stress the tissues a bit sooner than most.
Exactly. So within each phase, there's specific treatment goals and exercise goals. In the inflammatory phase, we want to prevent disruption of the new tissue and give plenty of time for rest. So here, we're probably not going to exercise at all. Like I said, this is 2 to 3 days after injury. You want to give that area time to rest. Compression, elevation, electrical stimulation are just some of the treatments that the book highlighted in order to assist the athlete in decreasing pain, because they will experience, like I said, a lot of pain, inflammation, redness, swollen during this time. So we want to help aid this process as best as we can.
Right, and it's helping them through that mental phase of the healing process too, right? So they're kind of in shock that all this has happened still.
So fibroblastic repair, the number one for treatment goals is we want to prevent excessive muscle atrophy and joint deterioration of the injured area. So if the tissue is always, wherever there's tissue, there's always a muscle or a joint around it. That's just how our body works. So if our tissue is unwell, our muscles and joints are going to try to work harder in order to build back, in order to get stronger. And so we really want to work here to make sure that everything is working properly and developing in the proper amount of time. So, the athlete mentally is going to think, oh, I'm ready to get back. I'm ready to get back. And it's like, no, you're not. You need to use this next amount of time. If it's an ACL, it could be up to 6-8 weeks. So you really need to use this time in order to get your body back to the state that it needs to be. But some of the exercises that are prescribed You can do isometric exercises. However, isometric are very joint specific. So it's going to only focus on that one joint rather than moving to multiple areas of the body. Isokinetic are going to use and provide resistance as well, but they are only one joint. So isokinetic exercises, if you're working on the knee, you're really just working the knee. You're not really working any of the other areas. Isotonic, we go to the concentric, eccentric, stretch shorten that we have focused on in previous PowerPoints such as this. And those have proved them to be very effective in helping the athlete rehabilitate. And more specifically, eccentric has been a greater development of strength compared to concentric. And the neuromuscular control is our ability to respond to sensory information. So if we're a cross-country runner, it's our ability to detect, okay, there's a curb there, I have to step higher, or this is uneven terrain, I need to be able to balance in this uneven terrain. So that is one of the primary exercises that can be used during this time.
Right, and I think it's important to also have the athlete back into a team environment as quickly as possible. Whether that's just going out to putt with some friends. If you're clear to walk and go on bicycle rides and things like that aren't going to be harmful to the injured area, or it's like a recumbent bike, things like that, there's no reason that you couldn't go out and putt depending on the type of injury. So it's always a difference from player to player, based on, okay, how quickly can I get back to play. Obviously, look at golf, for example, and some of the higher stress, higher speed type activities are obviously going to be driver, longer swings, with the lower irons. But if we get out to putting, or even just like little chip shots, green side, that's low stress, low impact on the body, that might be something that is helpful to rehabbing that injury, and isn't going to set us back. Now, we always want to pay attention to how we're feeling right after that session, and then we can take a progressive step forward. The main goal is not taking that step back.
So then goals of the final stage, maturation remodeling. So we want to optimize the tissue function. So in the last phase and in this phase, we're building back up the tissue. So the tissue is healing. The collagen has transferred from type 3 to type 1, and it's building around that area, and we're increasing our level of strength here. So the number one thing is we want to progressively load. Not all at once, but progression exercises add more advanced sport specific. And it also depends on what season the athlete is in. Are they in season? Are they in off season? So the more sport specific exercises that we can add back in, then the better the athlete will be able to respond when returning to sport. So in our program design, once again, it goes back specific adaptation to imposed demand. It goes back to what sport is the athlete in and how does this affect them. So the goal of training should dictate the design. So when we talk about this SAID principle, then it's stating that whatever the demand is, whatever the sport is, that's how we respond. So if we're focused on an injured marathoner, this type of athlete is not a power athlete. This athlete is a muscular endurance-based athlete. They need to have as much energy as possible for as long as possible. Whereas if we're talking about an Olympic weightlifter, this individual needs a power. So this athlete needs quick power, fast power, for short amounts of time. So we can focus on aerobic and anaerobic, whether or not we're whatever type of system that the athlete will require for oxygen. Marathon runners are typically aerobic, just because they're going back to that endurance-based aerobic system. The aerobic system is usually used for endurance-based. And then if we're a wrestler, then it depends upon what kind of challenge the wrestler is facing. So they usually need a combination of aerobic and anaerobic. They need a lot of power, but it could be over a longer period of time. And then an Olympic weightlifter needs anaerobic fitness. This type of fitness is going to give them a lot of power fast in order to lift those kinds of exercises, those power cleans and power jerks that we do in our performance section, but they're doing it with 200 and 300 pounds. So that is why anaerobic fitness is so important for them.
Right, and golf kind of falls in the middle there as well, where the golf swing is under 2 seconds, very anaerobic power demands of the sport. But we also have a time issue as well, where we want to be able to have the same amounts of power over the course of 4, 5, even 6, unfortunately, hours of golf. So we need a little bit of that aerobic capacity as well.
So reducing risk of injury and re-injury. So previous injury is one of the most prominent risk factors for future injury. So it can be divided into upper extremities and lower extremities. Decreased glenohumeral range of motion, so we're going to the shoulder. A lot of athletes really struggle with this if they don't have a lot of internal rotation, they don't have a lot of external rotation, or as we're loading back up, they might turn too much. Or if you are a caster, like I am, it's something that I really struggle with. I tend to throw from the top, and so I tend to throw my shoulder. Because I have that decreased range of motion, I don't have as much stability there that I need, and it leads to a lot of shoulder pains anteriorly and posteriorly. So that's something that I really had to work on within the past couple of months, really working on getting my lower body in the swing as opposed to working so much from the upper body. And once again, there it is, decreased shoulder strength. That is something that can significantly create future injuries, tendonitis in the biceps or even in the triceps. Lots of different issues going on up in the shoulder. And for lower extremities, we struggle with decreased balance, decreased neuromuscular control, and decreased muscle strength. So if we don't have a stable base of support, it's going to be very difficult for us to move adequately, and therefore creating future injuries. But in order to reduce our risk of injury, all movements after we have completed that tissue healing phase should be sport specific. We should be moving more into adjusting the athlete back into his or her respective sport.
Right, and the best demand for testing that would be the sport itself. So it's getting them out into practice, them getting out to play, maybe just going out to play a couple holes to see how you're feeling. And then you can gradually take steps forward to getting back to 18. So if before the injury you're playing 5 days a week, it's not going to be wise to go back to playing 4 or 5 days a week right away just because you're back into play.
Exactly.
Start off the first week maybe just playing once, and if you're feeling okay, get a round and a half in or 2 that next week. Then you can slowly, gradually get your way back to health. Otherwise, you run the risk of making this more of a chronic issue rather than getting back to the course for the long term. And over the course of a year, you might play more if you're slower to come back, as opposed to rushing back into things. So I thought this was a really good highlight of some of the things that we do in terms of rehab and reconditioning, taking a player that's maybe come off surgery, has gone through physical therapy, and is kind of in that limbo position of, okay, I've done my physical therapy, but I'm really not ready to get back out onto the course yet. Just because I don't have any pain reaching up to the cabinet, great. That doesn't mean anything for getting back to playing golf, because that's a much higher demand. And for us, we want you to be capable of handling higher demands than the sport is going to really challenge you with. And that's really how we're going to be able to recondition you back to a spot where you're not going to have the likelihood of re-injuring that area in the future. Nice job, Ailsa.